If I can just start by saying a huge thank you to everybody for joining this event, and a massive thank you to everybody who was involved in organising the event. So on my sort of screen, I'm looking particularly at Catherine Loftus, Katie Shar, and Christian sort of Bunting. But of course, there was a cast of a sort of 1,000 who contributed towards making this happen. This event was actually requested by the local authority. It seemed like a really good idea to take advantage of the fantastic community that exists across the schools, across the sort of teaching staff, across the sort of head teachers, across the different academies sort of trust and maintain schools, and so on and so forth within the sort of a region, and to ensure that all of the learned good experiences that people have had could be shared more widely. So that's the purpose of today. What we'll do at the end of today is produce the readout of this meeting, and an edited highlights sort of section will be made available. We're going to get some people to professionally produce a sort of video that hopefully will be a benefit, not just to schools within the Bradford area, but more widely, so that schools can learn from all the fantastic experiences which are represented within this call. So just waiting, I think, for sort of Dinesh, who is just going to give us a bit of sort of a background on the current state of affairs with regard to COVID in the Bradford sort of district. But I can't see Dinesh yet, but I can see a fantastic colleague of mine, Anil, who's a paediatrician at the Bradford Royal Infirmary. So Anil, if you don't mind, I'll hand straight over to you now, and if you can just sort of talk a little bit about a paediatrician's view of the COVID sort of a situation, and then if you can talk a little bit about distinguishing COVID from the common cold. So if I can hand over to you now, Anil, thank you very much.
Thank you, Mark. So my name is Anil Shanna. I'm a consultant pediatrician here in Bradford Royal Infirmary. So obviously COVID is new to us, and clearly is come with its own challenges itself over time. The good news, at least for me as a pediatrician, is we have not seen anywhere close to the number of children who have been affected with COVID compared to adults. And how do I state that? Mainly because the number of kids who have been affected with COVID are literally between 15 and 20 since March, who have been admitted to the hospital. And many a times they have come in with very non-specific symptoms, and some have been picked up accidentally than truly being an illness itself. Worldwide, we know COVID has spared the children, and plain and simply, it has not caused as much effects in children itself. And the number of children who have been affected with COVID, who have required hospital admissions and then gone on to intensive care, is literally a handful. This is across the globe itself. So in other words, children do not seem to be as susceptible or have been affected as much from COVID per se. The ones that we have seen, some of them have come accidentally. For example, they have come in for some problem with their finger, and then we have done a swab like we would do for kids who come into to the hospital, and then we have noticed that they have turned out to have a positive COVID result itself. But the long and short of it is, we have not seen children being affected or have needed lots of treatment, unlike our adult counterpart. And I would hope Dr. Sarlaya may be able to tell us a little bit more about adults. But in children, we have hardly seen the ones who have required any more treatment, any extra treatment. Yes, some have required some antibiotics, but that's like with any other kid who comes in with an infection itself. So with the first wave from March till now, if you look at Bradford, Bradford and the number of kids who have brought into the hospital or who have stayed overnight or for a slightly longer period, have been more like between the 15 and 20s, if you wish. Compared to adults, this is a very, very, very tiny number who have been affected. Yes, there is a variant of which you might have heard in the news, where children can get inflammatory process, but those are the sick ones. But they are so so infrequent that literally in our own practice, we have had about 2 or 3 kids who have been affected because of that itself. So in other words, children do not seem to be being affected from the coronavirus infection per se. Now, you may ask me, what about the kids who also have quite vulnerable or have flu vaccine or have flu at the same time as well? Yes, this is a time when children have gone back to school. They mix and mingle with other kids as well, and invariably they will get, they might have the common flus itself. But so far, we have not seen lots of influenza so far in the hospital as well. And if I were to compare the number of kids who have come in and who have stayed overnight this time last year, in September last year till now, and our biggest numbers or the kids who have been affected or a disease process, if you wish, is asthma itself. So if you compare the number of asthmatics who have come in and stayed overnight, if you compare them this year to last year, we are perhaps less than half have required a hospital attendance, for example. I think so. So clearly, we have not seen the footfall or number of kids who have come in, even with other illnesses, for example. So clearly, kids do not seem to be affected or seem to have been too troubled with the virus itself. Yes, once they come to the hospital, we do go on to give them treatment where appropriate, but the majority seem to have recovered and have had no ill effects from that itself. I'm happy to take questions, or Mark, it's entirely up to, I think how
we take any questions now, and then Anil, if you could just perhaps quickly talk through how people might distinguish between the common cold and the COVID, which I think was a specific sort of question that people were interested to hear. So
that's a bit tricky. That's a bit tricky.
I know. We could. We said ask any questions, Anil. We couldn't vet them for difficulty, I'm afraid. So does anybody have any questions for Anil on that topic? Seems good, sort of, Anil. So perhaps if you could speak specifically to that issue about knowing the difference between cold flu and COVID-19 symptoms in children.
So actually, to tell you the truth, as I was telling earlier on, the kids who seem to have been affected with COVID, we have picked it up incidentally. For example, they have come in with very, they have come in with problems with their hand, for example, or they've come in with an injury, and then we have done a swab and they've turned out to be positive. Or there might have been some kids who have come with very minor non-specific illnesses itself. But the ones that the flu, which is normally the influenza, which we see at this time of the year, they do have variable symptoms, of course. That includes temperatures, runny nose, cough, coryzal symptoms. And of course, there is an overlap with kids who have been affected with COVID as well. So there are kids with COVID who have had some minor symptoms, but that's nowhere close to the ones that we see with influenza. So of course there is an overlap. There is no doubt about it. There is an overlap, and sometimes you can't differentiate the two unless and until one undertakes a test. But so far we have not seen a big rise or a big spike of influenza as such.
That's great. Thanks so much for that, Anil. So again, I'll just offer the opportunity to ask our expert pediatrician any questions. So has anybody got any questions that they'd like to put to a pediatrician? I'll give the opportunity for a few minutes to ask the questions, and then we'll hand over to Duncan to hear his public health messages. But has anybody got any questions for Anil?
Can I ask Dr. Neil, this is Niall Devlin, can I ask Dr. Neil if children seem to be less able, seem to be more well if they have the infection. Is there any evidence regarding whether or not they're more likely or less likely to spread infection within schools?
Uh, I think that's I think my colleague, the public health doctor, might be able to answer that specific question. But as such, we have not, I think yes, it's like any other virus, I suppose. I think I don't, but we have not seen that they have necessarily spread as such, or at least the ones that, of course, I can only speak to the ones that who come to the hospital. You see. I think so. I can't speak for, but the ones that who have necessarily come into the hospital, they don't seem to have then spread it on to their colleagues. If that's what you are to their schoolmates or to the rest of the family members. If that's your question.
Thank you.
Great. Excellent. Any other questions for anybody?
Yes, could I ask Dr. Shenoy, please? It's Dominic Wall, head teacher at Co-op Academy Southfield Special School in Bradford. In the UK, Public Health England have identified this thing, the big three symptoms which access testing. But in other medical jurisdictions, like in America, the Centre for Disease Controls, in its review of pediatric COVID, it identifies a much broader spectrum of symptoms, which it describes as being equally likely to present in the case of children with COVID, which is puzzling for us in schools because we have children presenting with a range of illness symptoms in school, only some of whom are eligible for a COVID test. And I just wonder if you think there is any sort of particular insight for us in Bradford in terms of how we should view symptoms of generalized ill health in regard to COVID.
And can I just ask, just for clarification, how broad have they gone for these, the CDC team? I think have they been much more broader itself, because we normally follow the British, I think we go by the Public Health England rather than by the CDC.
Oh yes, no, I'm very aware that we have to follow the English public health guidance. The CDC lists fever, fatigue, headache, myalgia, as well as cough, as well as loss of taste or smell, but also sore throat, abdominal pain, diarrhea, nausea and vomiting, and poor appetite.
Yeah, and there is an overlap in lots of these. I think clearly, I think when Mark asked me that question earlier on, can you differentiate between COVID and non-COVID symptoms? And sometimes you just can't. I think you cannot tell categorically that one trumps over the other itself. I think so. You cannot say these are the only symptoms for COVID, or these are the only symptoms for flu, for example. I think there is a big overlap with some of these symptoms itself. I think so. I would, if you were to ask me, I would just say I would go with Public Health England guidance right now. I think, of course, one has to. The ones that who have had diarrhea or who have had abdominal symptoms, yes, these are what we call the sicker end of the COVID kids, but they are few and far between. As I was mentioning, we have only had about 3 so far. We had 1 kid last week, but as a rule, if you look since March, we must have had about 3 kids who have been affected with what we call PIMS TS, which is an inflammatory process with lots of diarrhea, lots of abdominal pain, and who are really sick. But they are few and far between. That cohort is very, very, very infrequent in the majority of the cases. Sorry.
That's brilliant. Thanks so much for that, Anil. Just to be clear, when Anil's saying listen to Public Health England's advice, everything apart from the bit about Excel spreadsheets, forget that bit of it. Right, so without further ado then, we'll now hand over to Duncan, who will talk through the public health messages that he really wants to get across. And the idea here was that there's lots of pieces of paper going out, and Niall was sort of saying how difficult it is for people just to really keep on top of all those sort of pieces of paper. And we felt that it would just be really good for people just to hear Duncan sort of talking through the messages that he'd really like to get across to schools. So Duncan, can I hand across to you now, please? You're on mute, Duncan.
Every time. So we've got about 20 minutes for this section. And what we're going to do is split it up. I'm just going to sort of try and get some key messages across. I've only got 2 slides, so I don't want to talk to slides. I want to sort of talk to you really, and then Georges, who's in my public health team as well, is going to give a bit of an overview, a bit more detail about some of the lessons being learned and experience of contacting you all as well with schools, because some of you will have spoken to Georges on the phone as well. So I think the thing to do to start with is probably just quickly bring you up to date with the data and what's happening across Bradford District. So since the start of term, we've now got 140 schools that have had confirmed positive cases of coronavirus in staff or children. Within half of those, there's about 70, they've got 2 or more cases. So we'd class those as clusters. But most of the infections are being brought in from the community in individual cases from household clusters. What we're not seeing at the moment in many schools is definitive evidence of transmission within the schools that develop into outbreaks. So there's probably 4 schools at the moment that we're liaising with quite slowly where we think there's in-school transmission. But that's out of a lot of schools, and some of them, some of the big secondary schools now have got up to 30 cases, 40 cases in some circumstances since the start of term. But that in-school transmission doesn't seem to be happening in a big way. And going back to the question earlier, we do have some good data on infection rates in Bradford for different age groups. And the age groups with the lowest infection rates at the moment are the 65 plus, and I think that's largely to do with social distancing within that age group. But we are seeing a bit of a worrying increase in trend in hospitalisations now for that age group. And then the other age group with the lowest infection rate is the 0 to 18. And I think probably part of that is the fact that a lot of children are asymptomatic and it's impossible to tell whether they have coronavirus if they don't get tested. But we've been surprised by how some of the bigger numbers of cases in schools haven't really taken off in an exponential way. And although it's not definitive evidence, that does seem to be adding to this emerging global evidence that children don't play such a big part in the pandemic as adults. It's all the other age groups, the 18 to 50 year age groups, that the infection rates seem to be really taking off in Bradford, whereas it's the 0 to 18 that it is rising, but it's rising at a lot slower rate. So that's just to give you a bit of information back. In terms of the cases in schools, at the moment, about 55% of those are staff, and the other 45% children, and that's been pretty constant since the start of term, that ratio, slightly more staff to children. And there's probably 4 schools at the moment where, as I said, we're probably concerned that there's some sort of in-school transmission going on. So what I wanted to do to start with is just quickly share the escalation framework, because we've spoken to many of you on the phone, we've been in email contact with others, and it might seem at times that there isn't a system, but there is a system. It doesn't work perfectly, and we have struggled to keep up with the workload with 140 schools with COVID cases, but we have got a framework, and I just wanted to quickly take you through those. So I think my screen's been shared, so I'll just try and share this with you. Can I just check that's working? Is that can I just have a yes from somebody if you can see that?
Yeah.
Yes.
Yeah. Okay. So this is the, as you'll know, nationally there's a contain framework, which is the government's 4 tiers, and we're currently in tier 1, which is all children at school. And depending on what happens in the country, that will gradually move up through tiers 2, 3, and 4, whereby secondary schools go to 2 weeks on, 2 weeks off, and progressively more and more groups don't go to school until it's just key workers. So we're currently in tier 1, and these 3 sub-tiers, I suppose, are how we escalate our support for schools within that current framework. So, as you know, we're asking all single or new COVID cases, even if you've had them before in the school, to be phoned through to the Department for Education helpline and to report those to the local authority. So we've got a quick web form on the local authority. We do take that information and we scan through all that every single day. and that enables the quality and accuracy of that information, and enables us to, I suppose, triage and prioritise the schools where we think that we might need to provide some more support. And our approach really with the majority of schools is, because there's over 250 schools in Bradford, is to reinforce those preventive measures, around hygiene, hand control, washing hands, 2 metre social distancing. And then what we've done on Bradford Schools Online as well is we've provided you with specimen letters to be able to deal with parental queries. We've got a guide now, a sort of a quick Q&A for parents that we're going to have translated into Urdu and other languages as well. And then we've also got other sort of one-page posters that are designed to really quickly take you through some of the things that you need to do, and the IPC checklist and so on. But George will talk a little bit more about that. But if we think that numbers are starting to increase, the Department for Education will escalate that and hand you on to Public Health England. We know that there's delays in these lines, and I know some of you will be sitting thinking, there, I've spent 2 hours waiting on this line, we never get anywhere. It's not a perfect system at the moment, but we are still relying to some extent on the DFE helpline, just because there are so many schools with coronavirus now. And what that allows us to do is take that decision, and if we start to see what we think are bigger clusters of cases, of between 5 and 10 cases, we escalate that, and we have a working list of schools that we're supporting. So there's usually 20 or 30 at any time that we're supporting. And that's when the school would be phoning Public Health England, reporting information through to local authority. We have 3 meetings a week with Public Health England where we discuss the information that's coming through and decide which schools that we want to try and provide support for. And we're also taking evidence coming back from schools as well, and through the education team. And where support is being asked for, we try and be as responsive as we can within the local authority. So the additional sorts of measures that we're recommending there is what you can do in school to minimise staff and student contact, reduce perhaps some of those extra activities where there's potential for transmission within the school, start to increase home learning, and also, as more and more cases build in the school, it becomes more and more important, obviously, to review those risk assessments around particularly extremely vulnerable staff, and really start to think about whether those staff members can work at home for a couple of weeks while the exclusions go on. So that's our second tier, and as I say, we support that through phone calls, and we've had a few visits to schools as well, and we try and do as much as we can there. And then the third tier, if you like, of the escalation is if we think there's increased vulnerabilities. So if you've got clinical vulnerabilities with cases in special schools, that's something that we look at. If we get extra information back from schools or the community that there's been hospitalisations or deaths linked to cases with families in the school, there's suddenly a rapid increase of numbers, or particularly a rapid increase in numbers in the same bubble or year group, that's when we escalate that to an incident management team or an IMT meeting. And we do those all in cooperation with the school, and we hold those every 3 days with the school until we think that the situation is under control. And that will be a joint effort from Niall's team within the education team within the local authority, Public Health. Public Health England will always join those calls. We always have people from the school, either head teachers, deputy heads and so on as well. And then we have specialist communications experts as well there to help with the communications that school might need. And the sorts of extra things that we do there are in a few cases we've had emergency test kits that we've been able to use. We ask for more information about line listing symptomatic cases, because that just speeds up our response. Reviewing school risk assessments and giving schools either temporary or 2-week closure opportunities to get deep cleaning in place and so on. So they're very intensive, those ones, and take a lot of time to organise. So that's why we don't do that often, because we have to make sure that we're prioritising our team to support the schools that we feel need the most need in terms of support for that week. So that's things in a nutshell. I will emphasise that every school and every school incident is different. So those guides, things like 5 or 10 cases, they're ballpark numbers really, and there's always something different about every school that we deal with, and the sorts of information that the heads feed back. You know, it might be or it might be additional staff, it might be a senior management team. There's all sorts of different scenarios, but that's a general way how we escalate, and we're trying to support schools at the moment. So I know some of you don't get the information and support that you need as quickly as you want it sometimes, and I do apologise for that, but we're trying to do everything that we can, and we're trying to prioritise those schools. So that's just a really quick overview. One of the other things that I just wanted to get across, because we are still seeing schools perhaps that have the first case or first couple of cases that are reading the guidance around interpreting that around identifying contacts, and we're seeing 3 or 4 classes isolated because of single cases in school. And I recognise this is difficult. It's a bit of a dark art identifying contacts sometimes, but I just tried to summarise the expectations because they're different across different key stages. So within key stage 1 and early years, because it's so difficult to keep kids from mixing with each other, usually that whole classroom would be identified as a bubble, or as a classroom that needs that two-week exclusion. But with staff members, I think this is really important. It's only really contacts that are specific identifiable individuals rather than whole groups. So if you've got a case of a child that's been out in a playground with 100 other children, it's really about thinking about their close social network, rather than saying that child could have been in contact with any one of those 100 children, so they all need to go home for 2 weeks. Because we are trying to keep children in school as much as possible. It's a balanced approach, but we'd ask you to try and be specific about those individuals. Don't feel that you need to have to exclude huge groups of people just because you're unsure who they might have been in contact with. And then, particularly with key stages 3, 4, and 5, and this is guidance from Public Health England, the default is not to isolate the whole class, and certainly not the whole year group, unless you've got good evidence that there has been mixing. So again, look at the seating plan, look at the social networks of those children, and if you can't guarantee that there hasn't been mixing, large mixing within a classroom, you might have to isolate the whole class, but really think about those specifics so we can try and keep as many children at school as possible. Do you think you can just unshare the screen now, please, just so you can see me again, because those are the only 2 things that I wanted to say. Okay, so can you just see a blank screen now?
See you now.
All right, okay, thanks. So the other things that I just wanted to get across, and I will take some questions in a minute, is the other thing is about leadership, and I'm sure what you're seeing is that there's still a lot of parents within Bradford that haven't got a good idea of the COVID symptoms, and haven't got a good idea of the fact that the whole household needs to isolate for 14 days if there's a positive case. We're still getting teachers reporting to us that kids are coming to school from COVID positive households. So there's a real leadership role, I think, for teachers as well. And I think all those sorts of conversations that you have at the school gates and with parents, and all that information that you send out via emails and things to them, is really, really important for those communities. We've not seen infection rates come down in some of the areas of central Bradford, and particularly sometimes with the language barriers, it's really difficult to get some of those messages across. So there's a real leadership role in communities as well for head teachers. The other thing that I wanted to say as well is, from speaking to head teachers on the phone and just from all the information that's coming back, I know that this is really, really difficult, and that you're working extremely long hours. There isn't a break at the weekend, because things just go on and on and on. And every time we think we've got something under control with COVID, it seems to throw a completely new challenge at us. So, and I'm not saying this in any sort of false flattery. I am completely in awe of the way that you've adapted to this, and the way that you continue to adapt in really difficult circumstances. So I just wanted to say that, because I think that the response from Bradford schools has been amazing. I think the final thing that I'll say is, it's about leadership, it's about basics, and also it's about that we haven't got the perfect system yet. I'm working with Niall's team about how we can provide a little bit more out of our support for schools so they can get it as early as possible. And there's been some stuff in the news about different lockdown measures that might be coming in Monday. There hasn't been any mention of schools being involved in that additional lockdown at the moment, as far as I know. I think that the national policy is to try and keep students in university and in school, but we'll let you know anything more about that as well. And then the final thing before I hand over to George is we are sending out weekly messages, public health messages to you via the head teachers briefing that comes around from the local authority. If there's anything else more that you want, get a message back to us. We're trying to put everything that we hope will be helpful on Bradford schools online and trying to simplify it as much as possible, because I know you get huge amounts of information. But let's keep, as I said before, let's keep the communication going, and there's still a lot of water under the bridge with this term and next term. So if we just keep that communication open, and if you're responsive and let us know what we need, we'll try and do as much of that as possible. Okay, so what I'll do now is just for the last 5 minutes or so, I just wanted to hand over to my colleague George in public health, who's just going to go through some of the key points that come back in terms of his liaison with school around infection prevention and control. So George, I'll hand over to you.
Okay, thanks, Duncan. So I'm new in this team. I'm working with you since the beginning of this term. So we started together in this response of the schools to COVID. And my role in the City Council has been basically to liaise with schools, to call the schools that have more than one case, and to support any decisions that need to be taken through gray areas, decisions that need to be balanced by the context or by other difficult factors, for example, like lack of staff or anxiety and things like this. So although I am based in public health, we are learning a lot also from the partnership with the educational team. So what we've been doing basically is trying to navigate through the uncertainty that the schools need to face with these COVID cases, and kind of mix public health guidance with an ongoing learning and experience that we've been building together. So I'll talk through now 5 areas that I highlighted in which I think that public health guidance and experience are coming together, and that we have some small lessons to learn from schools' experience that can help the schools, so lessons from one school that can help other schools to better prepare and respond to COVID cases. So I'll just share my screen with you. So the idea was to talk about infection prevention and control. So in schools, you've gone through these, you've made a risk assessment, you cleaned all the homes, you have alcohol gel and all. So the thing is that what is the room for improvement that we still have in terms of hands hygiene and indoors ventilation, environmental cleaning? So what can we really do to still improve the protection of the school, the environment of the school, to keep it more safe, and how we can respond to complex situations in which the rules do not necessarily apply immediately to our setting. So one of the areas in which I realized that we need we can improve a little bit is in terms of the environmental changes for schools. So everybody has alcohol gel and sinks for cleaning, and everybody is cleaning the rooms, but there are some small areas in which sometimes we can miss, that sometimes we can forget about them. For example, shared classrooms need much more attention than the rest of the environment of the school. So for example, one of the things that some schools are doing is reducing a bit the time, the duration of some of the sessions to avoid a more deep cleaning of shared classrooms, for example, labs, arts classrooms, in between different groups using those classrooms. So there is some room for improving in terms of cleaning if we use some of the imagination. So how we can adapt a little bit our timeline, our timetable of classes to allow a more deep protection in these shared environments. This is mainly in dinner and lunch areas, and in labs and arts and other shared classrooms. The other thing is that there is growing evidence that ventilation is really important as a protection factor. So although we emphasize a lot that COVID is transmitted from person to person, if if the people are in a small enclosed environment for a lot of time, even by keeping some social distancing, so virus can circulate through the air. If we are able to ventilate better the rooms, for example, keeping the doors open or allowing, for example, basically is keeping the windows and doors open, we can mitigate a little bit the fact that the children and the staff are confined in an enclosed space. So the idea is that we can have an additive approach to risk. So the idea, for example, of using face masks and social distance is just like this. So one thing adds to the other in terms of protection. So it's not if we are following 2 meters or less or more than 2 meters, but the farther the better. It's not if we are being able, for example, to wash the hands for 2 minutes, but the more the time and the more attention that we put on this, the better. So the same with these safety measures in schools. If in a small room, for example, we are able to ventilate the room, if we are able to increase the distance between, for example, the teaching staff, the teachers, and the students in that room, we can increase the distance, diminish the risk, so reduce the risk of contagion in that environment. So one school, for example, that I visited was able to, 2 schools were able to do this by changing all the furniture that was in the back of the schools, for example, bookshelves and archives, to other rooms or to the sides, and in this way they gained 1 meter in terms of distance between the first row and the teacher. So the teacher does not need to stick to the wall anymore, and he can move around and be a little more free in the lesson, and the environment feels a little more natural in this way, and it's still more safe. Other areas in which sometimes we don't pay so much attention is the informal contact between staff. So for example, tea rooms, plenty of schools have already kind of compartmentalize these, separating staffs in groups and having small groups having breaks in different times, and separating, for example, 2 or 3 different kitchens for assigned groups of staff. So this is one area to pay a lot of attention. That is about the informal contact, mainly between staff and staff. We have seen that at least half, sometimes more of half of the cases in schools are in staff and not in children. So they are an important source of transmission and also of prevention. The same with car sharing, for example. We have observed some cases of transmission between staff that share a ride for home. So this is something that should be avoided and should be highlighted. Some schools had, for example, all the leadership team down because of COVID. Because we think that there are no children, we are just here keeping an office. This is a kind of a safe space, and not necessarily. So some schools have moved to team A and B, for example, or to rotas of the teaching, not the teaching, the leadership and office staff, to avoid a lot of people in small rooms. Usually the offices don't have such good ventilation, for example, as I said previously. And the other area in which we can also have some improvements is the contact tracing. So Duncan talked about the definition of contacts, the importance of clearly identifying who are the contacts of the identified case in school in terms of avoiding mass isolation of students and staff. I have one example, for example, of one school that had 2 cases in year 10 and 11 and needed to isolate more than 200 students, because in the first instance, they understood that all the students had been in contact with each other. And it's not just a matter of understanding that they have been in contact, because there are some things like, for example, the seating plans were not clear. When the students moved between classes, it was not clear if they used defined corridors or defined pathways. So there was some room for improvement from this first case to the second case that will eventually happen. So the same school learned from their experience. They reduced the crossing teaching. They changed some arrangements for lunchtime, for example, to avoid contact between supporting staff and students. And then they have a 3rd case in year 12 and were able to isolate 12 instead of 240 students. So there is room for improvement, and we can discuss this kind of thing together. Another area that I highlight is the decision on who should self-isolate. Duncan has already talked about this, but just one thing that I want to highlight is based on this example that I gave to you. In secondary school, mainly, it's very important to keep very detailed mapping of the movement of students across classrooms. So if we are able to have a timetable of the classes and to clearly define where the students moved, for example, up to 10 a.m. in the morning when they were first isolated and sent back home, we are able to isolate less people, and we are able to be more confident to the students and to the parents that we are making the right decision. So we are making these decisions based on a very thorough assessment of the context that this case had with other students in classroom. Another area that sometimes we forget because we are overwhelmed by the pressure is that we are all human beings, and we are also afraid of getting COVID. We also have doubts about the evidence and the public health guidance. So, for example, parents' behavior is a problem for a number of schools. Parents sometimes send kids to school, for example, that have symptomatic siblings at home. I understand that sometimes this is done because parents do not want to comply with the guidance. But in a number of other times, this is made because parents do not understand clearly the guidance, because it's confusing for us sometimes. And then I think we need to localize clearly what are the areas in which parents have more doubt, and it clearly reinforce compliance with some specific measures. So instead of telling the parents that they need to wear masks in the street or wash their hands because they are receiving this message through TV, tell them clearly that tests should only be offered to kids with symptoms, that you don't need a negative test to return to school, that contacts of contacts are not contagious. So this kind of thing can kind of reduce a little bit the uncertainty among parents. It's the same among staff. We also had cases of schools in which staff with 3 days, 4 days, we usually have use 48 hours between before the beginning of the symptoms as the definition of contact. So if someone has been in touch with a symptomatic case more than 48 hours previous to the symptoms, it will not be defined as a contact. But people who have, for example, other health issues, or who were concerned that it was a little bit more than 48 hours can be afraid of this. So we also had schools in which a number of staff self-isolated voluntarily for fear of getting COVID from another member of staff, and they didn't fulfill the definition of contact. So this is something that should be extensively discussed to avoid panic isolation, panic self-isolation, and anxiety, growing anxiety in school, leading to sometimes rushed decisions and operational issues. The fourth area is about the changes in teaching. So this is something that we are still discussing with education. This is an area in which we still have a lot to learn, but there are some changes in teaching that do not affect significantly the curriculum delivery that can be made. For example, I mentioned reducing the duration of some of the sessions to allow the better cleaning between classes in shared classrooms. So this is one example, for example, of changing the teaching plans. Another one is trying to reduce the maximum possible the size of the bubbles and avoid mixing up of the bubbles. So another area is to reduce the mass movement of students. So for example, is it possible that instead of students moving across different classrooms, this is not possible in labs, for example, but this can be possible, for example, in a Spanish classroom. Is it possible that instead of students, mass of students moving across the school, just the teacher moves to a designated area in which the students are sitting for most of the day, so we are able to better track contacts in this way? So there are a lot of things that can be made in terms of changing in teaching that I think needed to be discussed with us and with education at the same time, because we can have a public health reasoning for this, but you have the live experience of delivering education for the children. Splitting the office staff, for example, in TIS, as I mentioned. So this is another area that I highlight as an area for improvement. The last thing that I would like to highlight is that most of my work has been to build trust relationships with the head teachers and the teaching staff in the schools. So I am here since just 1 month, and I'm not afraid of talking to the head teachers anymore, because in the beginning I had never called the schools and talked to you that had the authority in your environments. So who am I to provide any guidance to someone who has been through so many sessions of risk assessment and previous pandemics of diarrhea and etc. So what I figured out is that my role is much more a point of contact and support for hard decisions that none of us has the right answer. But if we share these decisions with different knowledge and backgrounds, we can have more confidence that we are doing the right thing. So what is happening is that we have a learning system in which health and education backgrounds, evidence and lively experience are coming together to produce the kind of knowledge that we need to go through this situation. So there is a lot of uncertainty, and there will always be, but if we kind of draw on the experience and match it with the best evidence that we have, we can have more tailored guidance and more detailed guidance on how to act upon uncertainty and hard situations. So we are producing tailored guidance for you based on this, based on this match between evidence and experience. And we are producing kind of posters with 1 page of actions, contacts, and resources to what should be done if you have one single case, if you have more than one case, if you have an outbreak in school. So the idea is that the framework that Duncan showed would be converted into small action cards that you could act upon and use as a checklist to action. So we're trying to produce the more tailored guidance possible to support you in this hard task. And I can only finish with kind of the same clapping that we have for the NHS staff in the beginning of this lockdown period. I think we should have for the head teachers and all the teaching staff in school and all the staff in school. So I'm really learning to admire the hard work and the hard leg work that we are doing together here, but most you than me, definitely. I'm here for questions and answers afterwards. Thank you.
Great, thanks so much for that, George, and thanks so much again to sort of Duncan. Really insightful. I think lots of things for us to sort of talk about there. Couldn't agree more with what you said about us needing to celebrate the amazing sort of work that our sort of teaching staff are doing across the sort of a district. Really, you know, the heroes that are looking after our next sort of a generation. So heartfelt sort of a gratitude. We will be having lots of opportunity to discuss all of these issues. What I'd like to do now is actually just bring in Dinesh. So unfortunately, Dinesh was supposed to start the whole of this event, but was actually busy vaccinating people. All kinds of exciting projects happening within Bradford on vaccination. So we're the only other centre outside sort of Oxford that's doing work at this sort of a scale. So if I can hand over to Dinesh now, who's just going to sort of talk us through the current state of play with regard to COVID in the district. So Dinesh, can I ask you to just give a quick roundup of COVID across the Bradford district, please?
Thank you, Mark. Sorry for delay. We've just completed our day of vaccination of with the Novavax trial. So yeah, currently as we see, nationally over 14,000 cases reported, the single highest peak in a day of COVID-19. If you compare it to the peak in April, where we were reporting about 6,000 cases, hospitalizations have tripled in the last 2 weeks in the Bradford Royal Infirmary. Same time, 2 weeks ago, we had 23 inpatients with 1 patient in intensive care. And today we have 70 patients with 5 patients in intensive care. So the numbers are quickly rising. John Wright had produced a wonderful graph in July and August where there was continuing in high prevalence cases of COVID-19 in Bradford, but this is not translating into hospitalizations. But sadly, now we are seeing a steady rise in hospitalizations. And as I won't go into the causes of why COVID-19 is so prevalent in Bradford. Certainly, we think the multi-ethnicity of our city, the multi-generation households, crowded housing, social deprivation, and people in frontline, people facing jobs where there's a higher risk of developing COVID-19, lesser chance to work from home in desktop jobs would be contributing to that. What we've seen over the past 6 months, Bradford has been particularly hit with over 50% of our patients admitted from the South Asian community, though I would class them as BAME, but it was predominantly South Asian, Pakistani origin. For some reason, we didn't see a lot of Gujarati community admitted to Bradford. And I think vegetarianism may have a role in that, or maybe stricter social isolation and smaller family size in the Gujarati families as compared to the Pakistani families would be playing an important role, in my opinion, there. Now, we nationally, we were very much in the concerted research effort. Many of you all might have heard of the big news which came over the weekend with Donald Trump walking and parading himself after having a monoclonal antibody for COVID-19. And we've been involved in Bradford through the pandemic in the research effort to find a cure for COVID-19. And we're now joined the race to find a vaccine as well. Bradford is one of 5 patient recruitment centers in the whole of the country. I'm very proud to lead that as the director here. But through the pandemic, we've been able to recruit into what we call big urgent public health badged platform COVID-19 treatment trials, one of them being the recovery trial, which is the largest COVID-19 treatment trial, which currently has 5 arms in it. In children, we are particularly using a low-dose steroid called dexamethasone, which has already got a license to be used in adults with COVID-19. But there's an antibiotic called azithromycin, which is commonly used in clinical practice. But the 3 other arms are very, very novel. One is called convalescent plasma, where we're using the plasma of people who have recovered from COVID-19 and hoping that the antibodies in their blood would fight against COVID-19. People get 2 doses of convalescent plasma from 2 separate donors to help patients. And the 2 other arms, which have recently been added, are Regen COVID-2 monoclonal antibody from the company Regeneron, which Trump was infused on Thursday, I think. And then he got better and he's back in the Oval Office. Now, just that doesn't mean, I was in the press yesterday, just because it worked on him, it doesn't mean it works on everyone. It's still an experimental drug. And the concept is precisely why children don't get COVID-19 is because they don't have well-developed ACE2 receptors in the lining of their airways. COVID-19 has a spike epitome and a protein which binds to the ACE2 receptor, which then implants its RNA into the cell and multiplies within our cell. And as it multiplies into our cell, it causes a dysregulation of our immune system, causing all the problems that we see. Most patients with COVID-19 come to harm between the 5th and the 12th day. In our particular case, we've seen a lot of patients even admitted after the 14th day with problems with COVID. What is happening, what is different, is that we've been able to give many of these patients these novel therapies through the recovery trial. So the recovery trial, I call, is a ray of hope in the treatment in finding a cure, but there are other studies as well. We are participating in another study called TACTIC, which is also recruiting patients. And most importantly, there are 2 or 3 very, very promising trials started in COVID-19, one being a monoclonal antibody separate from Regeneron, but this basically goes into your body and produced by a company called AstraZeneca, produces a vaccine-like effect. So those are the treatment trials. What has happened is in-hospital mortality has still been between in the range of 15 to 20% from COVID-19. Vast majority of people dying from COVID-19 have been above the age of 70. Children in particular do not come to the harmful effects of COVID-19 because they don't have these ACE2 receptors well. But in a city like Bradford, I think children can act as super spreaders, taking the virus from the topic that you're discussing precisely and the great work that you're doing in schools to halt the spread into families where there may be elders in multi-generation households. And we find it's usually the youngsters in their 20s in Bradford who take the infection home, and very often a vulnerable adult in the family then ends up in hospital. Sadly, in our hospital, 50% of our hospitalizations of over 1,400 patients in the last 6 months in Bradford we have treated. I myself have looked after over 500 patients with COVID-19, and over 50% of these people who have died sadly succumbed. Over 290 of them, of the 1,400, have sadly belonged to the South Asian community. So there's been a great research effort, and combined with this, we've had to tackle all the misinformation which has been circulating in the social media. And I myself went to the Central Mosque in Bradford last week just to allay some of those fears about COVID-19. There's a great deal of apprehension, which then translates, I guess, in some of the work that you're doing with the children in school. And I think my own feeling is, and I felt a personal duty to go out and reach out to the public with the experience that we have in treating COVID-19. We've done some splendid things in Bradford. We've used patients who have recovered from COVID-19 as COVID champions. And one such patient was an 18-year-old lady who received dexamethasone, which now is standard of care, and recovered from COVID-19. And she's been a wonderful ambassador for us. Try hoping to dispel some of the misinformation which has been circulating in our community, most of which is not originated in this country, but from abroad. So coming back to what we are doing now in Bradford is joining the race to find a vaccine. We are one of 2 centers in Yorkshire running a large phase 3 COVID vaccine efficacy trial called the Novavax study from a biotech company in the USA. This is the phase 3 of this trial. There are phase 2 trials running in India and Mexico and some parts of South America. But the phase 3, you can see the accelerated development of a vaccine, and most politicians talk about a vaccine early next year. It's probably through this phase. Normally a vaccine takes years to develop. But we've accelerated phase 1, phase 2 together, and now phase 3. So phase 3, for people who have not know much about clinical trials, is what I call the Rolls Royce in getting a license for any treatment, which recruiting large number of real life population. So the Novavax study is recruiting 10,000 subjects in the UK, and 1 in 20 of those subjects will come from Bradford. We've got a target of 500. We hope to exceed that. We have vaccinated 75 individuals in 3 days. We'll be continuing to vaccinate over the next 3 weeks to achieve our target. And then it starts all over again because people receive a second booster dose at 21 days. So we've had our own microsite as well as a national registry. Unfortunately, only 4% of the signups belong to the South Asian community. Rather disheartening, despite the work we know that is the community which has been disproportionately affected with COVID-19. And we know, and we won't know whether a vaccine works in that community. And we might probably, and if there are people, champions in the South Asian community on this call, probably spread the message that we'll continue to see deaths in that community unless they come forward and help us with some of these clinical trials. We've had great successes in the treatment trials with over 50% of our patients belonging to South Asian, but they're a sick group of patients nearing death's door, and they're happy to take part with anything that helps. But in the race to find a COVID, you're looking at healthy volunteers who are scared that the virus may be in those vaccines and that this is all this conspiracy theory about the virus being spread through these vaccine trials. So I myself today, I had the personal experience of talking to 2 subjects who had that in mind when they asked me the question, can I get COVID-19 by taking part in this trial? Quite the opposite, I would say. If you take part in a vaccine trial, you've got a 50% chance of having an antibody develop against COVID-19. But I think the greater the number of South Asians we hope to at least represent our population, as you will know, 71% of the heart of Bradford belongs to Asian, South Asians. So your BD8, BD9, BD10 postcodes. And as I won't need to tell you, there's a 14-year difference between inner city Bradford in the mortality and outer areas of Skipton like BD23. So you got to think what we can do as a city. And if there's something that you guys can do to spread the word that COVID-19 is here to stay until we find a vaccine, because the only strategy of exit from COVID-19, we can't rely on herd immunity. The concept is died virtually because we have seen patients lose antibodies after 2 months and get reinfected with COVID-19. We've had 3 such cases in Bradford who had COVID-19 in March, proved with antibody results in April, and got COVID-19 for a second time in July and August. So sadly, COVID-19 immunity through herd immunity is not something which we can rely on. So we got to develop a vaccine. And the negative side in me says that this vaccine race may be a long drawn one, because if the virus doesn't respond to the vaccination strategies, then we'll have to think of other alternative strategies, and we may have to live with COVID for a long time. But hopefully, looking on the optimistic side, if these vaccine trials work, and I think they are working, because they would not proceed to phase 3 if they didn't work in phase 1 and phase 2. I think we should have 2 or 3 vaccine candidates by spring, and we may be in some form of an exit strategy. And I think the strategy worldwide would be to vaccinate vulnerable and healthcare workers and people in frontline jobs like yourselves facing COVID-19 first, before we then reach out to the other sections of our community. So with that, I'm happy to take any questions, but the fight is very much on, and I think we'll have a tough winter this winter till we get out of it in spring.
Dinesh, thank you so much. And it just ties in so well with what Duncan was saying about what an important role everybody on this call has to get the message across and to encourage sort of other people to participate in these vaccination sort of trials and encourage people to sort of stay sort of safe. Duncan does have a question for you, which is how long do you expect the vaccine immunity to last?
So we think that the vaccine immunity will depend on what the first dose immunity. So for example, in Novavax, we do a baseline antibody titer, and then we do 3 subsequent titers at 35 days, 3 months, 6 months, and then a final one on 12 months, which is optional. If we are able to hold an antibody titer or a rising antibody titer which sustains itself at 6 months, I would say that we will be probably confident in rolling that vaccine out to the general public. And that's what politicians talk, because I think the Oxford is already showing that. But we're going to need 3 or 4 vaccine candidates until, I think, in my opinion, to come out of this pandemic. And you must remember, we are not vaccinating people in nursing homes and those in wheelchairs with multiple immunosuppressed conditions. So we're just vaccinating mainly, the Oxford has vaccinated only healthy healthcare workers or those with chronic stable conditions. But we've got about 40% of our community with some form of a health issue, especially in Bradford. And then we've got a high proportion of people with genetic problems and people in nursing homes and the people with multiple medical problems. That will be a huge challenge when we have to get out of COVID-19. So we're not going to get on like that with the switch. Exit is going to be very slow and painful, I'm afraid. and dare I say, probably take the whole of 2021 in it.
Okay, sobering stuff. Thank you so much, Dinesh. And again, thank you so much to George, and thank you so much to Sir Duncan. I think just to try and keep us in some semblance of staying on time, Dinesh, I know you've got to leave and do other sort of vaccination work. Any questions, if you send them through to Katie Shire, we'll put them to Dinesh and make sure you get an answer back. But in the interest of time, we'll just say thank you so much again to Dinesh. And what I'll now do is just ask one of our fantastic head teachers just to give their insights into managing and reporting on an outbreak. What happens if it's late in the day or 5 p.m. on a Friday? So John, if I can hand over to you and just ask you to share your experiences with us, that'd be fantastic. Thank you.
Thank you, Mark, and hello everyone. I'm John. I'm the executive head at the three Keithley Catholic primary schools. Well, what a few weeks we've had. It's been interesting, hasn't it? Uncharted territory, I think we can call it. And I mean, one of my biggest concerns at the moment, genuinely, is staff well-being. It's very, very, very hard working in schools at the moment. It really, really is. But the good news is it's nearly Friday. So what I'm going to talk about now then is my experiences, because that's all I can talk about really. And one of the questions was, what happens if you get a case 5 o'clock on a Friday? Well, to be honest, that wouldn't be too bad, because at least you've got a bit of time to get things sorted. Can everyone hear me okay? Good. It could happen anytime. I've had positive cases I've been informed of positive cases at 6:45 in the morning, 5:15 in the evening. The last one was whilst I was sitting in a car park in Whitby on a rainy Saturday afternoon. So it can happen at any time. The first one, a couple of weeks ago, we had a phone call from a member of staff at 6:45 a.m. that she tested positive for COVID. She'd been off the day before because of she was feeling poorly. And obviously parents were due in with children at 8:20 in the morning. So you've got to get busy. It doesn't help that obviously the phone line doesn't open until 8 o'clock from the DFE. And it was the first case that we'd had. So we had to get quite busy very quickly. So we informed a few key members of staff, the early years lead, because it was a nursery bubble that was affected, school business manager. We had a message ready to go out on the MyEd app. All we needed to do was press send. So it's really important having all that set up. I'm glad we spent a lot of time last year making sure everybody had access to this app. That's really, really helped. We got lists of phone numbers ready as well, just in case parents didn't have the app. And then we went round to thinking, has our bubble remained intact, so that when we rang the DFE, we would be able to have the right kind of questions. Then on the dot of 8, we rang the DFE. And in my experience so far, I've found them very helpful indeed. And I've amazingly, delightfully been able to get through to them quite quickly each time, which has been fabulous. And the support from them, there's a girl called Suzanne, who was it yesterday? I don't know if she was the health protection team. Very knowledgeable, really good, able to answer the questions. It's been super. They helped us realise that in this case, that anybody who'd been in contact with that member of staff for the previous 48 hours, to her symptoms starting, would have to isolate. So anyway, once we'd spoken to the DFE and it was clear what was going to happen, we got rather busy. Obviously, we sent out the message immediately. We assigned jobs to various members of staff, someone to message on the app, someone to print off physical letters which were sent from the DFE, someone to meet parents at the door with the letters ready in hand from the nursery bubble. And somebody to answer the potential tide wave of phone calls that we were expecting. The first one, it went quite smoothly, really. In fact, the parents were very understanding. And the good thing was, obviously, as the class hadn't been in school that day, because it was before school, there was no immediate panic to start deep cleaning areas immediately and things. We had a little bit of time there, so we had time to get to that. So that one went quite smoothly. Another example was when we found out at 10 a.m. that a bubble had to close. It was a year 1 bubble at a different school. Again, we rang DFE straight away, just to double check that we were doing everything correctly. Because we knew that there'd been a positive case in that class and the class were in the building, we immediately cordoned off that area so nobody else would go anywhere near it. We obviously informed the staff in that bubble to keep the children where they were. And then we got very busy on the MyEd app again. I sound like I've got shares in MyEd, but I haven't. But it has been quite useful. And we also got lists of telephone numbers. We had people ringing parents. And amazingly, we were able to actually get all the children home within an hour. And again, we had parents who were very supportive. And the thing to do, once you've obviously, you cleared your bubble, that we do have I've got a list of things that we need to do. We need to ring the local authority. We need to ring, in our case, the trust, the Catholic Trust, chair of governors, that kind of thing. So we've got a list to make sure that we've done everything correctly. And it's about getting the information out as quickly as possible. Then once you've closed the bubble, obviously we have to provide continuity of education. So before they went home, the teacher and her teaching assistants had a brief meeting to arrange what they will be teaching over the next, 2 weeks. Fortunately, we decided a couple of years ago to go down the Google Classroom route. So that's been very useful. It was quite easy. And in the previous few weeks, we've been getting the children logging on and getting ready for it, because we all know that a bubble can go at any time. So it's really important that that we're prepped, basically. And it's gone okay. We've got about half of the bubble have been engaging, and the other half, well, they're back in school on Monday, thankfully. But it really is about preparing in advance. So a few things to remember, and obviously I can only talk from my experience. Be prepared, get a list, get those phone numbers on your wall, get a team together. Who's going to inform the parents? Who's going to man the doors with the letters? Who's going to inform the rest of the school? Cordon off and clean the areas, get ready for phone calls, and then your list of people to call. And then when it's all done, just have a cup of tea and finish the crossword, because it's it's been intense. Been intense, it really has. So that's from my point of view. Obviously, I can only talk about my own experience. I know everybody's had. It sounds like most of Bradford have had these kind of issues, but I just wanted to get it off my chest and share what's happened in my case. And I'm sure that we'll find out as this conversation continues other people's experiences as well. So that's it for me, unless anyone's got any questions.
Thanks so much, John. I think we'll take sort of questions in the sort of a breakout sort of group just to keep us on sort of at our time. But so much sort of thought-provoking stuff there, and I just utter admiration for what you and everybody is doing. Thank you so much. So what I'm now going to do is hand over to John Skerr, who's going to talk to us about communicating with parents effectively. So John, can I bring you in now, please?
Yeah, thanks. Good evening, everyone. Yeah, it was interesting to hear from the health. I think it's Dinesh talking about sort of the information in the communities. My school's in a very predominantly South. We serve a South Asian community, and communication with parents has been key for everything for us. And through the whole pandemic, we've learned a number of lessons along the way, and we've refined our communication as we've developed throughout the whole process. And I'd love to say it was in a good position now, but it keeps changing, and as every day is different for us, it puts challenges on us. Because of a lot of our parents speak English but don't necessarily read or write it, we have issues around some of the communications for us. So we've had to really adopt a belt and braces approach. We try and pride ourselves being on transparent and clear, and try and calm our parents down, because as we all know, there's been a lot of misinformation in the South Asian community about the risks, and and young people taken into care if they catch it, or the risk at school, etc. So we've spent a lot of time sort of allaying fears and educating the parents about what we're doing at school. So we generally have a belt and braces approach to communication, where for every text or for text we send out, we'll send a letter. If we're making phone calls, we follow that up with another communication method. We do use social media and websites, but we don't rely on any one form of information, because we know that different strategies work for different groups of our parents, and different parents will rely on different people to translate or give them that information. We spent a lot of time identifying parents, whether they would utilize technology or if they had technology accessible in houses. We identify students that have language issues, or any students at risk or are vulnerable. So we have different strategies for different cohorts of students, depending what their parents or family needs. Now, unfortunately, we have a big pastoral team and we have a support admin team which geared up to deal with this. And it is really a team effort, and we have regular team meetings to discuss the strategy around that. Throughout the process, or while students are off, we commit to 2 phone calls a week to parents to check on student, check on well-being. That happened through the whole pandemic. That increased to three phone calls a week to a vulnerable student, so a vulnerable family. And obviously with some of the issues around the food vouchers, etc., that was very challenging for us. But we also then have the form tutor to phone. So if we have a cohort off at any period of time, we have a wellbeing phone call every 2 weeks to the student on top of the other phone calls that are making. And we speak to the parent and the child. And sometimes the child's translating for us, but we do have a number of different language speakers who then will pick up communications with a variety of families. Senior leaders then identify groups that we will deal with and positive relationships. We have some community members that really struggle with engagement at school and some beliefs around the virus and that we have to adhere to, and then also we have to educate our parents around school access, school impact. They want to come in, they want to, I mean, I think the first week, I don't know if anyone else's school was like it, I had 600 parents arrive to pick kids up, which we've never had in the past. We had to shut car parks, we blocked the main roads were blocked, and so we've had to put additional measures in place. But with communities that where possible, we try and get out, we speak to people, obviously socially distanced and wearing visors, but we put a number of strategies in place to support them, to try and minimise their concerns and fears. What we do have at school is when we've had outbreaks or cases that have come up, we have a clear script for our admin teams and our support staff and our pastoral staff, so that everyone is clear on the information they're giving, and we try and de-escalate parents' concerns and also de-escalate staff and student concerns by being transparent about that. Obviously, extra provision and safety requirements are constantly developed and given to parents so that they've got faith and that school is dealing with all these issues and making sure their young people are really safe and well. Obviously, we have a number of parents who are worried about the academic effect, and one of the strategies that we developed over the lockdown period and now has gone on continued now, which seemed to work even with language barriers, that we RAG rated students' effort and engagement across subjects. And that was obviously the simplest way, where parents saw subjects were read and then wanted to get in touch and wanted to engage with us. So we saw our academic engagement over the pandemic and lockdown period increase significantly. And so that's a strategy now that we use straight away when we send a cohort, or if we have to send a cohort of students home. So as soon as a cohort goes home, there's a 2 or 3, they get the initial letter, then there's some follow-up conversations with parents, and then by day 4, we're already starting to RAG rate how they are doing. And from a teaching perspective, so it's not workload, it is literally tick box at the first instance if they're engaging in work. That for me is one of the biggest impacts that we've had, that I look back on the whole process, say that really helped us in our communication with parents. So they're just some of the things we're doing. I'm not going to, I looked at what to do, and I was just thinking, if I talk to you about what we've done, it's not for everyone. As a smallish secondary, it's been a challenge, 650, 700 students moving towards, and it's something that we've developed over the last 6 months, and we've got to a point where we're happy-ish with it. But when I sent a cohort home the other day and the Sims broke down and didn't send out till late, and then I had students turn up in the morning to separate, it wasn't ideal. But we're developing, and our parental feedback so far has been quite positive about that. So that's just how we've managed it here at UAK, and I'm sure some other people have got some great ideas how they manage it in their schools.
Fantastic. Thank you, John. Some really great advice there. So hopefully we'll be able to pick up some of these things in the breakout groups, but to give us time to speak in the breakout groups, we're not going to take questions now, and I'll go straight to Lynette, who's going to talk to us about collapsing bubbles and maintaining staffing levels. So Lynette, can I bring you in now, please?
You can indeed. I'm Lynette. I'm Executive Head at Crossley Hall Primary and Grove House Primary, and 2 very, very different communities that we serve. We've had 12 positive COVID cases for adults at Crossley Hall, and a period of around 2 weeks that I can only describe as the most emotional and stressful 2 weeks of an academic year. We have a designated specialist provision for children with autism at Crossley Hall, and that was where COVID started for us, and actually 7 members of staff were positive in that unit. It's very difficult to socially distance in that unit, and it made life very, very difficult for us. Like other people have mentioned, and we've heard from professionals about cases being through community transmission, that's the advice that we had as well. I would say when it comes to collapsing bubbles, like John said earlier, just preparation is key. We did successfully use an Excel spreadsheet to be able to do this. And from the moment somebody was showing symptoms, we tracked that date. And from that day, we started to look at who had they had the direct contact with 48 hours before. So whether that test came back positive or negative, we had that information in place and we were absolutely ready to go with it. The information was useful as well as when we'd got, you've got your 2 cases and that's escalated through the process and public health become more involved. But by the time we'd got to 7, 8, 9 cases and were being asked questions of, well, when did symptoms start? When was the first day of absence? When was the test result? To have all that information at your fingertips when you're going through quite a lengthy phone conversation was really, really useful. It was then about planning for us. So the first case we had, it actually just affected 9 children. So between myself and the head of school, we made phone calls to those parents to explain to them what had happened and that they needed to come and collect their children. The confirmation came through around 2 o'clock in the afternoon, so we were very swift to take the action for parents to collect and to have siblings of any of those children ready as well, so they could just take them for that day at the same time. We confirmed the procedure around siblings not having to self-isolate unless symptoms are displayed in the house, and parents understood that. The third case came through on a Saturday afternoon. So collapsing the bubble then and making sure that children didn't come to school on the Monday morning was more of a challenge, but we'd done it a few times at that point. So we knew quickly we'd already worked out splitting up the children and who would ring who. We chose to make phone calls, and that was just the approach that we took to reassure our parents of what was going on and give them an opportunity to ask questions. They were incredibly supportive. They did not have any issues with what we were doing and have continued to work with us. It then came down to timing, as well as what other people have said. Having a telephone script ready for the phones on that Monday morning so that the office staff knew what to say. And because we'd had so many cases, the authority worked with us to have a press statement ready at that point as well. We made the press on 2 cases, but thankfully we've not made it for 12 cases, which is quite incredible and a relief to me. Communication, again, I know we've mentioned this, but if you can work with your staff around understanding those symptoms and try to reassure them slightly, then when they're the ones on the doors that are handing children over at the end of the day, any quick questions we can answer, then we're able to do that to reassure them, and that's been really helpful. We have had fantastic support from public health and the authority on this. They offered to come and visit us after school, look at risk assessments with us, and just answer any questions, just to go through things. We have a giant wooden pirate ship in the playground. Do I close it? Do I leave it open? How do we clean it? Those kind of practicalities around the issues that were going on. So that was really helpful. And for us, we've been able to put those risk assessments in place at Grove House as well. So that was really lucky. We've worked then on our strategy of educating the community. Staff, when we all go out at the end of the day, we're present, but we are present with masks on, and we model that for our families, and we encourage them to do that as well. And we're seeing more and more of that happening now. It is a way of life for our community, and they're responding to that very, very well. We were blessed, shall we say, to have had our Ofsted visit today as well. So we've had the interim visit experience, and to be able to share what we've done with Ofsted and for them to reassure us that we are having the same experience as other schools and we're doing the same things as other schools has meant that potentially I might sleep a little bit better this evening as well. I think the other thing really to mention that we did, every time we had a case, it was about reviewing what can we do differently, what do we need to look at next time, this isn't going to go away, but it's looking at minimising the contact. So actually the first 3 classes closed because a member of staff had gone from one for an hour to another to another. We could have avoided that, and we fully recognise that. And it was making sure that didn't happen again. So what capacity had we got in year groups, in classes, in year group bubbles, where we could cover classes internally through teaching assistants? We don't usually do that, but the circumstances led itself to that. But just so that we could plan ahead for when that happens. We have no positive cases in school, so we've had a very tricky 2-3 weeks, but we hope now that we can do our best to manage this situation as well as we possibly can. Thanks.
Thank you, Lynette. That was brilliant. Yeah, and we're just about to hear from somebody about how they find interacting with Public Health England, and perhaps can ask why there's no information about what to do with your pirate ship, which seems a real lack of information. Right, thank you so much, Lynette. What I'm going to do now then is go straight to Rob, who's going to talk to us about his experiences of dealing with Public Health England. So if I can hand over to you, Rob, please.
Okay, thanks very much. I have to say, Lynette, 11 cases, that's just a huge amount to deal with. I actually feel lucky now that we've only had 2. But I'm pleased to say as well, it's calmed down here somewhat as well, because our first case came 4 days after we opened, and I did think, my goodness, is this how the term's going to be? We've only had 4 days and we've got the first case, but we have only had 2 actually at Saltaire Primary School. So I'm just going to talk through, as has just been said, our experiences of working with Public Health England. As a couple of people have said already, it has been, on the whole, a very positive experience having that contact with Public Health England and then the DFE. So I've had experience of working with both sides here. And I think just to say that the first thing really for me, I learned in the first experience was about managing expectations, because I kind of fully expected that I would ring up and someone would answer the phone immediately and then they would tell me what to do and I would go away and put that into action. And actually that rapid risk assessment, it wasn't quite as rapid as I was expecting it to be in the first instance. And I think what I've learned, and as we've heard this afternoon, it's not a perfect system and it's not going to kind of get you the answers straight away. However, I was very satisfied on both occasions with the advice that I ended up receiving. So as I said, our first case came 4 days after we started, and that was a child in one of our year groups. And the way that we had things set up here is that we have each year group is set up as a bubble with 2 form entry, but the general directive is that children don't mix between the classes apart from in reception and year 1. So that was our kind of first experience. The second was about 3 weeks ago, and that was a member of staff not directly employed by the school, but working within our school kitchen. And my immediate thoughts when that call came in at 8 o'clock on a Monday morning was that that Public Health England were going to advise me to shut the whole school. But obviously going through the kind of risk assessment and looking at how that was going to work, you kind of realise how little actual direct contact those staff have with children. So we weren't in that position at all, but we did find that our entire kitchen team had to self-isolate, which obviously led to its own problems in terms of our daily meal provision. So the first experience with a child with a positive case, that was at the point where we were still ringing Public Health England directly. I received confirmation of the case at about 2:30 in the afternoon, just as we were about to begin our kind of staggered home time. So I needed to complete that as we were in such early stages of that, and then I rang through to Public Health England. The initial person was someone who fielded the call for me, took some initial information, and then advised that we shouldn't take any further action until we had further confirmation from Public Health England. I received a number of phone calls then through the course of the evening. Each time I was sort of attempting to go home and think, I can deal with this from home, but then each time I started to pack up, another phone call came in. So it meant that actually in the end, it was about 7:15 when the agreement between me and the representative from Public Health England agreed to close the bubble. The good thing about it was, because I was able to talk about the size of the bubble and the fact that the bubble was split into two, if you like, with the two classes, we were able to confirm that it only affected one of the classes. So it did mean that only one class had to close. So it did lead to real minimal disruption in terms of the rest of the school and actually the whole year group. And I think one of the good things, if you can call it that, was that this was on a Wednesday evening. The child who had the confirmed case had last been in school on the Friday, which meant that actually we were already partway through that 2-week period. So it did mean that, you know, by risk assessing it with Public Health England, we were able to close for just 7 school days. And that did make it easier in terms of communicating that to parents. The second time I called the DFE helpline, and again, the phone line was already very busy at 8 o'clock in the morning. But again, the lesson learned from that is, you know, that you're just going to have a long wait, and you know, it's a kind of just making sure that you're patient with that, really. On that occasion, I think it still felt like quite early days in terms of the DFE involvement there, and it did feel at the beginning like they were reading through a script and kind of following the algorithm. However, I felt assured by the interaction with them, so there was no problem with that, but it did just feel a little bit like they were kind of feeling the way, and I'm sure that's kind of become smoother as the weeks have gone on. But as I said, I was really happy with the outcome and felt that the advice was really secure, and I felt like I knew exactly what I was doing when I put the phone down. There were some issues the first time, and again, because I think it was very early days in terms of the receipt of the paperwork, so I did find that I kind of wrote my own email to parents that evening because the information that came through didn't come until the next day. However, you know, that has become more readily available now. So I think probably most head teachers would feel secure being able to put that information out to parents. So just the things that I've kind of put in place and the advice that I would give, having gone through this experience a couple of times now, is to have as much information ready and available to be able to give to the DFE when you first call through, or Public Health England if that's what's required. And so I have now a kind of template set up. And I actually spend a little bit of time completing that just before I make the phone call. So I've just got it all to hand. So making sure you know how many children it affects, and they did want to know how many were in the whole school, how many were in the bubble and in the class. The same information for staff. And then, as a few people have said already, knowing who your direct contacts were so that you knew exactly who it affected. Knowing when the last point of contact was with the confirmed case and when the symptoms first started, so obviously they can track that 48 hours to know who's been in contact when they may have been infectious. I have this sheet created and I have all of the phone numbers I might require included. It sounds really straightforward, but actually it really helped me the second time round. And then, as John was saying before, knowing who's going to pick up the other aspects, really. So I was really lucky that although it was only me and my deputy head, we were able to kind of put the processes of home learning and informing the catering team and the cleaning team of what needed to happen next, because you do feel a little bit like you have to focus completely on what that phone call is going to advise you. As I said, take your time getting your information in place and be prepared for the process to last longer than you expect it to before you get a confirmed decision. Speaking to other head teachers just in the last few days, I know that it's been a number of days before they've actually confirmed whether or not a bubble should close or what action should be taken. And I think the thing I learned on that first occasion was I was advised that someone would call me back, and I'd wasted a few hours and I kind of wasn't certain. So I think just to kind of call again and just kind of follow it up if you feel that you need more clarification on what to do next, really. But I would say, although it's really good to have that clarification and obviously the go ahead to do what you need to do next, that on both occasions, I felt like I could kind of predict what the advice was going to be at the end of that phone call, because I think as long as you're following all the processes, which I know, you know, everybody in this room will be doing, you know, you can kind of predict what the advice is going to be. But I think it's just great that actually you've got somebody that you can pick the phone up to, you go through that process, and then you've got that kind of solid advice to move forward. So that's my experience of working with Public Health England.
Fantastic. Thank you, Rob. Yet again, really good sort of insights there and some great information for people to take away. What we're now going to do is ask Dominic to talk to us about meeting the needs of children with specific medical needs within both special schools and mainstream education. So Dominic, if I can hand over to you.
Thanks, Mark. Yeah, just like children with general special educational needs, they do span both the special and the mainstream sector equally. I'd been a head in Bradford in 2009-10 during the swine flu breakout, and we'd had a cluster of unexplained deaths in the special schools in Bradford during that period that was later considered to be swine flu related. So as COVID approached, we were very, very concerned about the impact it would have on our schools, and in fact we did close our schools in anticipation of the government lockdown. Children with a range of medical conditions, asthma, diabetes, those suffering cancer who are on immunosuppressant drugs, children with obesity, and those with long-term complex health conditions were all immediately understood to be potentially at greater risk. We've heard of the phrase shielding, and many children were put into the shield, but it was very difficult during the first lockdown period to find out any information about which children were considered to be in that category. Most children were locked out of school anyway, so it wasn't particularly impactful. When they reviewed the period of controlled reopening in May and June, and the amount of COVID-19 that actually was prevalent in schools, Public Health England's review reflected the input that we had at the start of this seminar from the doctors, which was there is a surprising fact, unlike flu, that actually COVID, childhood is a protective characteristic. And I've heard Professor Russell Viner, who's the president of the College of Paediatricians, saying that on reflection, his view now, knowing what he does know about COVID, is that actually probably children didn't need to be in the shielding category at all. The case numbers have always been dozens compared to the thousands in adults. And I saw recently that one of our public health professors is saying that children should be considered to be about a quarter to the level of risk of catching COVID. However, it is true that of the small number of children that do get hospitalized and get complications with COVID, actually, when they're reviewed, the single most consistent characteristic is comorbidities, i.e. other complex health conditions. So they're a really vulnerable group, and even though children are much less likely to catch COVID, if the children with the medical conditions catch COVID, that can be very serious for them. So one of the most significant vulnerable groups, which you may have come across because it's become a bit of a national concern since we've come back with all schools open in September, are those children with respiratory conditions. The most well-known such condition is a tracheostomy, which is when you have a tube to support your breathing. But there are a number of different types of respiratory condition which give rise to care procedures which involve suctioning the secretions in the throat. And these have been classed as aerosol generating procedures. What that means basically is when you use mechanical devices to clear the throat, it can create a very fine aerosol mist. And if this was a young person who was asymptomatic but carrying COVID infection, that could then generalize to anyone in the area around them. So this subpopulation of very vulnerable children also create a risk for others. And that's through this aerosol generating procedure, the acronym that we now know as AGPs. Now, when we did a review in Bradford in July, and Duncan, who's on the call, and Niall Devlin in the LA, and myself and others in the CCG were all involved in reviewing how many of these children are there in Bradford, and what work do we need to do to meet their needs, to keep them safe, but also to protect any others. We were really staggered to discover that there are over 100 children in Bradford schools who have this aerosol generating procedure care. And we already knew that there would be many in special schools. In fact, there's nearly 66 in special schools, and they distribute across our 6 generic specialist provisions. What we weren't really expecting was that there is another 30 plus children who are in 1s and 2s in a couple of dozen mainstream primary and secondary schools across Bradford. And these children need complex care. Whereas most head teachers have heard the mantra, you don't need PPE in a school, actually DfE guidance, which just reproduces guidance for clinical settings from Public Health England, clearly sets out for these subset children with AGPs, their care needs to be undertaken by staff wearing full clinical PPE, the same as on the red wards at the BRI. That's an FFP23 respirator mask, a full clinical gown, and that this care should take place in a designated room, which will then be held sterile after the care and empty for an hour and then cleaned down. So it's quite a complex, demanding procedure, and it hasn't been widely disseminated. So we are aware that in September, some children with these care needs did return to mainstream schools where they're normally looked after by medical specialist third-party providers, and they did come back into classes and join in with other children where their care tasks were undertaken live without PPE in front of other children. Now that is a real problem. So we are aware in Bradford that we've got some work to do to make sure that there is not a risk of head teachers in the category of don't know what they don't know. And that's why one reason why I'm very pleased to have the opportunity just to flag this up, that children with respiratory care in Bradford, there's a very good team effort from the CCG and care trust providers, from the local authority, from public health, and from special schools to really pull the expertise together and make sure that any school which is working with one of these children can access a really big package of support to make sure we get everything right for them. It includes, we've had infection prevention in public health in Bradford doing reviews of all the designated rooms to make sure that they're suitable for the care to be carried out. We've had support from the Bradford Teaching Hospitals Foundation Trust to ensure that all school staff who carry out these cares in school will have the proper FFP23 respirators issued from the stores that are usually secure for the NHS, and will have the proper fit testing. So that's been very interesting for us as special schools, because whereas 10 years ago during the swine flu, we basically had our fingers and toes crossed and no additional protective measures were taken, this time round it's very different. We've learned a lot quickly. We've had some of that disseminated to us today. I think a lot of very deliberative work's been done, and at the moment this group of children, 102 of them in Bradford, are not able to return to school yet, but we do believe that they will begin to return in the coming weeks as this collaborative effort bears fruit and we get the right care procedures into place. But if there are any heads on this call thinking, I'm pretty sure I've seen something a bit like that happening in my school, please feel free to make contact either with myself at Co-op Academy Southfield, or if you contact Niall Devlin in the LA or Duncan Cooper in Public Health, any of us will plug you into the collaborative effort that is working towards supporting these most vulnerable children in Bradford.
Dominic, that is brilliant. What a fantastic offer. I love that word collaboration, and I love just to see the way that everybody is coming together to take care of these vulnerable children. Thank you so much. Really inspiring stuff. What we're now going to do is move to Sarah, who's going to talk to us again about communicating with sort of a parent effectively, but this time from the perspective of a primary school. So if I can hand over to you, Sarah, thank you.
Okay, I'm going to be really brief because I know that time's running out. I'm head at Newby Primary in BD5. We've had 3 staff cases and 2 children cases. all gone very well. I think the main thing is, as I was preparing for this, I spoke to my parents. I know my parents really, really well, and I think that's key. I think one of the key things that for effective communication is knowing your parents really, really well, knowing your community really, really well. I think the main message I've had is we moved everything online. So right through lockdown, we decided the best way to, in a bit like John was saying really at UAK, was we decided that it was really important that our community, with their various languages and various expertise, got all the key messages. So we moved online and we created Newbie YouTube, and we moved all our learning on there. But I set up the Mrs. Rawnsley Roundup, which is the weekly wonderment of a newsletter, but me chomping on, usually with very bad hair, which was awful. But that's continued. One of the things that's been a big success in terms of communicating with parents is being very clear, very concise, and doing how-to videos. So I did a whole plan of what school was going to be like when it reopened. That went viral, which is a bit frightening, really. I had somebody phone me up from Staffordshire. But then we also have done an awful lot of our roles and our responsibilities. We really, really clear with everything we did. And we thought and walked the walk. And that was a really important aspect of getting our parents feeling safe and feeling as though they could send their children back without worrying too much. My school is predominantly a Pakistani heritage families. There had been dreadful rumours that we were going to take their children away. We were going to, we would isolate them from their families for 2 weeks. And that was quite simply put to bed through clear communication and a video and saying, we're not going to do that. I'm a mum. I'm not going to let anybody take my child. So why would I take yours? And our parents have been amazing. I think one of the things that I would say is you can't control the wind, but you can control the sails. And COVID is going to be with us for a long time, just as Dinesh said earlier. So it's a new way of working. There's been lots and lots of learning. My parents have been utterly fantastic, and we haven't had one parental complaint, not one, through the whole of lockdown. And I think it's because we know them, we're out there, we fed 30 families through lockdown, we did home visits, we know their situations and their needs. We've supplied everybody who didn't have tech with tech. We gave out all our laptops, and then we've brought forward our IT strategy by 3 years. We won't have the carry forward we will have, but this is the rainy day that we've all saved for. So it's about making sure that our parents felt absolutely as part of that plan, and listening to their suggestions has been hugely important. So now we know everyone. I know every one of my parents now. I'm out, it's visible. We model the PPE, as Lynette was saying earlier. We're out all the time in PPE, and we are clear and ensure our parents also wear PPE. We wear PPE in and around our school as well, particularly in and out of bubbles. We don't walk around, any of us, without PPE, and that's led us to having, I think, a pretty safe school. Actually, it's worked really well. So that's all I wanted to say. Fail to plan, you fail to plan to fail. So make sure that, it's just about being clear and concise, and I won't chunter on anymore. Thank you.
Sarah, that was not chuntering, that was absolutely inspirational again. You really are the frontline heroes. Just so impressed with everything that's happening. This is so important, and I've chaired it so awfully, we're now running over, but I think it's so important that we're going to try and do what we sort of set out to do from the outset. It will mean that our scheduled finish time is now at 6:15. If anybody has to leave, though, we have sort of mechanisms that are going to allow that to happen. So what we're going to do now is Katie, by the magic of Zoom, is going to put everybody into a breakout room. The rooms are now going to last for 15 minutes. So in a second, Katie will wave a magic sort of wand, and you'll end up in the room. If you end up in the wrong place, there's a help button, and you can let Katie know, and she'll move you back into the room where you should be. With 5 minutes to go, Katie will give you that 5 minutes sort of a warning. The facilitators will be there to coordinate the sort of discussion, and we're asking all the group facilitators to keep some kind of sort of notes and feed back at 6 o'clock to the whole sort of a group. And we're asking that's just a 2-minute feedback session. That will be recorded. So if anybody has to leave at 6 o'clock, they will be able to listen to that later on. And we are going to amalgamate all of this material, all of these insights, and make them available to everybody. So you won't miss anybody or anything. But if you can hang on till 6:15, that'd be fantastic. There is a request help button within your breakout room. So if you press that button, as I said, Katie will come and help. But you can also perhaps bring in Duncan or George or Anil, who can come in and provide any sort of our experts or medical sort of our support or inputs as required. So Katie, can I hand over to you, and can you wave your magic wand? Thank you to everybody. I just found this such an amazing event, and my breakout group was no different. Such interesting and important sort of insights. So what we're going to do now is just hear a quick 2-minute summary from the facilitators from each sort of a group, because I just think there's so much sort of a learning that can be concentrated. Again, if people do need to go, don't worry, these will be recorded. We will be making them available. But what I'll do is ask Rob, first of all, if he can just give us a 2-minute summary from his breakout room.
Yeah, sure. Thank you. So one of the things that came through, first of all, was about some confusion still around the 48-hour period of people being contagious before any symptoms may present themselves. So an example was given of a nail technician getting in touch, even though to say that they'd been in contact, even though it was actually a week ago since they'd last been, or several days since they'd last been in touch. So we had a bit of conversation around that, and what is my understanding, and I'm happy to be corrected on this though, is that it is 48 hours. So anyone that was in contact longer than 48 hours before the first symptoms presented themselves would not need to be classed as a close contact. We discussed the local authority email that comes out each Friday, and generally felt that was a positive thing, although I think it's kind of widely considered that there's some information within that email that maybe people don't need to hear on a Friday night. A couple of questions. So one was around, and again, if anyone's got any answer to this, maybe after I've finished speaking, is whether we're likely to get a definitive answer on whether half term is going to be extended or not. We're not sure that it is at this stage, but it's getting pretty close now. And is it likely that the 3 symptoms might change? Is it at all likely that those symptoms may increase in number as things to look out for going forward? It was generally, though, agreed that this webinar has been really useful, and we would like to see more of them going forward. And one of the topics that we're keen to hear more about is around looking after staff, more guidance on how to look after staff and their well-being going forward, as we feel that actually it's their health and well-being that we're most concerned about at the moment. So that's kind of the general topics from our conversation.
Thank you so much, Rob. And I noticed there's some questions there, so we will take our questions back to the people we feel are best positioned to answer those, and again, make all of those sort of answers available. Again, to remind everybody, if there are questions, just email Katie Shire and we'll compile those questions and we will get answers to you. But thank you so much, Rob. And what I'm now going to do is ask Sarah to give her summary from her group.
Yeah, it was an interesting discussion. Where one of the things that came out strongly is that our work with parents is improving over time as we learn new ways, improving our systems, making sure that we have that clarity. And there's some discussion we had with regard to those outlying families, families where, parents are pregnant, or where there are particular issues with regard to children who are more vulnerable, or families who are reluctant. And I would advise anybody to get in touch with the Hida Shah at attendance for that. We also talked about the growing number of families who maybe have wanted to do elective home education, and we raised concerns there about that safeguarding aspect and how much that's putting on maybe the teams at education and safeguarding. And then a couple of our challenges would be things like parent and teacher consultations when we're not allowed to sort of have people in. And we talked about the sort of staggered pick-up and drop-offs. It was really nice to hear that Dick Ballantyne was saying that he drove past lots and lots of schools this week. That's what I call him, Sam Dick. And he's not on his bike, looking like Boris Johnson. But all the schools had parents lining up, mostly in PPE, socially distanced. So our parents get it, and we're not fighting a battle. we're all in it together, and I think there is a general feeling with parents like that. Thank you.
Sarah, thank you so much. I'll now ask John to give his 2-minute summary.
Yeah, we had some great discussions, and we said that probably the summaries that have come out for us is the risk of staff-to-staff issues, about separating staff, making sure areas are split, and we try and minimise the risk to staff at all time. It then went on to some discussion about being mindful that it's daily decision-making from all members of the staff force that could put us at risk, and it's keeping it in people's mindsets. And it's hard sometimes when we were back in school and you start getting back to old ways of working and old habits, and it's just recapping on that and recapping on the sort of changes that we've got to make to protect each other and protect our young people. We also spoke about that this is a really long-term situation. I think the health professionals have told us today that this is going to go on for at least a year, and we've got a long year ahead of us, and it's how we manage that. And I think Mark's going to action a potential listening service for colleagues to talk to each other and listen to each other and help each other out. So, because well-being has come out a lot, and the well-being of everybody in this group is probably the most important of that, because you're running organisations, and if you break down, that's going to have a knock-on impact for so many people. So that sort of I think Mark's action in that, which I think will be a real benefit to all that lead schools. Thank you.
Thank you so much, John. Really fantastic stuff. And I'm now going to ask Lynette to give her summary.
In our group, we talked particularly about being able to contact public health. So there's were a few people in the group that had been advised by the LA that they should make the call to public health, ended up being on hold for a significant amount of time, which made the situation very frustrating. Whereas for me, I was told not to contact public health, they would contact us, which they did. And maybe some work to be done there around the process that needs to be followed, and that could come from the weekly roundup email that comes through from Mariam, and just clarifying that, because it is an ever-changing and ever-evolving picture, and the process isn't perfect yet, but keep that going and keep that up to date. We, I guess, celebrated in some ways that there were some schools in our group that haven't had cases as yet. So that's a very positive. So they feel that this has been really useful in being able to prepare them for potentially what is to come. We talked a little bit really about community understanding as well for parents. And I think we didn't talk about what comes next in the webinars, but I think for me there are clearly people in the group that are having real success with communicating with parents and supporting the understanding of COVID in the community. If we could share that and learn from that, we've got a lot of people in this group that are in very key positions to be able to impact on the community across the city, and I think that there's an opportunity there. That's our roundup. Thanks, Mark.
Thank you, Lynette. I can see why you're all brilliant sort of teachers. Incredibly fantastic how you managed to summarise all this information so concisely. And what I'll now do is ask John just to give the sort of final roundup from the 5th group.
Thank you. Yeah, we had very similar to discussions to everybody. And I think our group have had quite similar experiences of what's gone on as well in terms of contacting the DFE, Public Health England. But one of the frustrations, one of our group was quite frustrated with Public Health England. They've been asked, had quite a complex case, and we're finding it very, very difficult to get through to Public Health England. Although some of those of us who haven't had complex cases had only good things to say about the experiences with DFE and Public Health England. All of us seem quite well planned and prepped for providing continuity of education should bubbles go down. I think that's really good. We talked a little bit about the potential of a 2-week half term, which has been mooted, and we all agreed that we think the kids are far better off at school, and it's probably safer for everybody's public health if we don't have a 2-week half term. We're also, we are educators. We're quite worried about the catch up and about the gaps that have, these vast gaps that have opened up over the last 6 months. And we're very aware that, you know, we're under pressure to do something about this whilst in the middle of a pandemic, and that is certainly adding to stress levels, without a doubt. And like the other groups, you know, staff wellbeing is something we're really, really concerned about. Staff are on the knees. You know, people have found staff members crying in cupboards and all sorts of things. And we're only 5 weeks into this. And we know that this could be, you know, as we heard earlier, this could be for the next 6-8 months or however long. So it is something that we're all having to, you know, pay regard to in our own teams. And it would be quite interesting to hear good examples of how people are managing to cope with that. So that's it from me.
Thank you, John. And yeah, I mean, well said. We will get through this, but we're going to have to get through it together. We've got to work together. And this, for me, has just been a fantastic example of everybody coming together to support each other for the benefit of the children and young people throughout the whole district. I mean, it's really, really sort of heartwarming. It's only the beginning. I'm just going to quickly ask Christian just to sort of summarize what are the next steps. So Christian, can you just quickly wrap up for us, please?
Yes, of course. First of all, thank you to the head teachers and the other health and other professionals that have been part of this session today. Our intention is to have 11 further webinars this year, and that will be 2 every half term, 2 next half term, and then 4 in the spring term, we hope, and 4 in the summer term, where we will try to progress what I think are going to be some threads of learning across this academic year, and we'll pick up that issue that's been really significantly mentioned around teacher and head teacher well-being in those threads, and we'll circulate documentation that's been requested as a result of the conversations today as well. So we're going to try to keep going with this. This is going to be a medium to long-term effort here, and we need to keep these conversations going. I think it's been a really successful event today. Thank you, everybody, for your attendance.
Thank you, Christian. I just want to reiterate our huge thanks to everybody, absolutely everybody who's joined this sort of event. Massive thank you to our facilitators. Apologies to everybody for my terrible sort of chairing, but I do think that sort of everything that was said was so worthwhile. Thank you so much to our public health colleagues. So thank you so much to our hospital colleagues. Thank you so much to the organising team. Thank you so much to Niall and local authority for first encouraging us to get this sort of event together. So thank you, Katie, Catherine, and sort of Christian, for all your great work. As I said, we will get through this together, but it's not going to be easy. This is just the beginning. Any questions, anything that we can do to help within Bourne and Bradford, do just let us know. But we'll call it a day there. We'll be in contact. We'll disseminate all the materials. I wish you sort of well. And again, just want to say what utter respect I have. You really are the heroes of the hour. Keep up the great work. Good night. Thank you.